Hello, everyone. Good morning. I am Eithan Kotkowski. Many of you know me as neurology PGY3, interested in neuropalliative care. So I am here to at least present you one case that is relevant. Of course, there could be many hundreds of different kinds of cases, but I just wanted to share one with you that resonated with me and at least talk about neuropalliative care as a specialty. One thing that kind of a funny story, but when I was a kid, and both my parents would go on vacation, my dad would give me a list of things to do in case both of them died. And he would be like, okay, so your godparents, you know them, are Eduardo and Lily. They live in Mexico City. This is their phone number. If anything happens to us, you go live with them. This is our insurance agents. This is how much the house is worth. These are the valuable paintings we have at home. They'll all be here behind this painting. Okay. I thought that was totally normal. For most of my life, I thought every parent did that with their kids. At the same time, all four of my grandparents, every single one of my aunts and uncles, whenever there was something on TV or they heard about someone dying or someone getting ill, they're like, oh, I don't want to get there. I don't want to be like that. Please make me DNR DNI. My mom would always say, give me the little black pill if there's any indication that I'm going to start having Alzheimer's. I also thought that was totally normal. And then lo and behold, I come to medical school and I notice that my fellow colleagues barely have had any conversations about end-of-life care with their own parents or grandparents. And needless to say, our patients as well. So I come from a very interesting and apparently unique background when it comes to this kind of topic, which is why I'm very interested in it. So with that being said, let me begin by presenting you this case, okay? And for Dr. Palm, ChatGPT works wonders to create the rendition of my patient. Actually looks quite similar to this lady. So this is not her real name, Miss Gloria Elena Sandoval Iglesias, okay? And she is an 80-year-old right-handed Spanish-speaking female, mother of 11 children, from Mexico. She lives with one daughter and one granddaughter here in San Antonio. She has a past medical history of hypertension, hyperlipidemia, type 2 diabetes, AFib, on Eliquis, multiple abdominal surgeries with adhesions, a recent hospitalization for a colostomy placement complicated by an abdominal infection, also has a Klebsiella UTI, and intractable diarrhea. This lady is suffering a lot. She presented as a stroke alert for an acute left-sided weakness, dysarthria, and minor left-sided sensory loss. Her last known normal was 2 hours prior to presentation. Her blood pressure on arrival was 170/63. Her glucose was 97. Her NIH stroke scale was 10. She was not a TNK candidate. She was on Eliquis, and the CT head showed a teeny tiny interparenchymal hemorrhage. Needless to say, she just had surgery just a few days prior, so she would not have been a candidate for these interventions. She was having elevating troponins, which was a little concerning as well. They were small, but still uptrending. Because I responded to the stroke alert, I tend to like having these conversations, especially with patients who are at higher risk of, decompensation or increased morbidity and mortality. So I had an advanced care planning discussion with the patient and her daughter who was at bedside and confirmed that the patient would want to be DNR DNI. So at least we had that documented. For the neurologists and neurosurgeons in the room and neuro-ICU specialists, this was a teeny tiny interparenchymal hemorrhage that she experienced. Would not really explain her symptoms all too much, okay? That whole left-sided hemiparesis, sensory loss, dysarthria would definitely not be explained by that tiny little thing. Once we got an MRI, okay, we saw a larger lesion, the periventricular white matter, some part of the basal ganglia, but you also saw some little bits of embolic strokes, like little tiny ones that at least put us, with her history of AFib, maybe thinking that she was having some cardioembolic strokes. We got an echo, and the impression was pretty scary, a 2.21 centimeter hyperechoic mass attached to the posterior mitral valve leaflet. So yes, she had been off the Eliquis for a while for her abdominal surgeries, was just put back on right before she presented, and somehow maybe she had this lingering, but that's a pretty sizable thrombus sitting in her mitral valve. So we'll take a pause just for a second, okay, and discuss a few things. So this lady came in with a stroke. Stroke is, as we know, has a high risk of morbidity, very high risk of morbidity, and a high risk of mortality. And if we look at the map of the United States and we look at the most common causes of death, we all have to recognize that we're all going to die, okay? So it's going to be either heart disease or cancer or some complication or aspiration. So there's always going to be something that's the most common. Heart disease by far, takes the cake. But then we have cancer. And if we look at the second most likely cause of death, that is not cancer or heart disease, we start seeing accidents, which in my mind, I think of, oh, maybe these are, TBIs from car accidents. So potentially also neurological. But you have respiratory diseases all over the place and stroke everywhere. So stroke is very, very common as a cause for mortality. As far as the leading causes of death, this is from 2019, right before COVID. We see that stroke is right after ischemic heart disease. And also working its way up the list is Alzheimer's disease. In fact, this is even from 2015. The data is much different now. So 6.2 million people died directly because of a stroke in 2015. That accounts for at least 11.1% of deaths worldwide. Alzheimer's comes in at around number 7, and that number is growing. 1.5 million deaths, 2.7% worldwide. Okay, so all in all, at least 15 to 20% of all death globally is directly due to a primary neurological condition. But, and here's the thing, I actually just learned this. Do any of you get this thing in the mail? Neurology reviews that we all just tend to throw away? This one actually had an interesting title: Neurological Disorders Now Top Global Cause of Illness and Disability. And it says right here, as the world's leading cause of overall disease burden, and with cases numbering and rising to 59% globally since 1990, nervous system conditions must be addressed through effective, culturally acceptable, and affordable prevention, treatment, rehabilitation, and long-term care strategies. So yeah, I learned that not just mortality is rising in terms of neurological conditions being a burden, but also morbidity. So 59% of all morbidity globally is directly attributed to a primary neurological condition. And this does not take into account the heavy neurological burden of other primary diseases, namely HIV/AIDS, surgical complications, diabetes, metastasis to the brain and spine, long COVID, endocarditis, infectious diseases, trauma, hypertension, hypotension, therapy side effects, autoimmune diseases, hypoxic ischemia, and many more. Okay. And for those of you who know what palliative care is, often the biggest association is it's associated with end-of-life care. But I want to at least dispel that myth a little bit and expand on it a little bit more. So I like definitions. I like etymology. What does palliative mean? It comes from the Latin pallium, meaning to cloak or to cover. And that even comes from the root pellis, meaning skin or pelt. And I kind of like to think that in an alternate universe, palliative care and dermatology could have been interchangeable. So yes, this is a pelt, a covering. Basically, it's a way to address the fact that if someone is dying and they're cold, you give them a blanket to make them comfortable. That's kind of the image that it's meant to conjure. Okay. And as far as its actual definition, it is the specialized transdisciplinary medical care that aims to recognize, to prevent, to alleviate physical, social, psychological, and spiritual suffering, and to improve communication about quality of life for patients with serious illnesses and their families. It's, as you can see, end-of-life care, death is not in the definition, at least the definition that I like the most from my recent visit to the Palliative Care Conference. And this graph basically shows it. Oftentimes when we think of palliative care, we like to just think of this little bubble right here. Okay, it's terminal care. Once we've tried everything, okay, call palliative. They can come deal with, you know, the last rites discussions with patients and their families. But that's not the case. Palliative care is a whole multidisciplinary team approach, and the barrier to palliative care is actually, it doesn't have to mean that you're dying. It doesn't even have to mean that you know, are nearing the end of life or anything. If you basically are a patient living with a life-limiting illness with any prognosis, you can get palliative care. That includes, you know, a newly diagnosed 20-something-year-old with multiple sclerosis who probably has a very close to normal life expectancy, but we know that their disease is progressive and it will cause disease burden. There's symptom management. Okay, so palliative care is very good at managing symptoms. Pain in particular is what it's most known for, but any form of symptom management focuses on maximizing quality of life. So whereas the traditional medical field tends to focus on quantity of life, we like to think that we're good at balancing both, but at the very least, palliative care can help emphasize the quality of life portion. And the other one I find very important is psychosocial support. Oftentimes, patients come in with a traumatic brain injury, with newly diagnosed glioblastoma, with MS, with Parkinson's, and immediately they get started on therapy and follow-ups and everything, and they never really get that chance to understand their disease. What are the stages? Where does it go? What are my options? And that's what psychosocial support is all about, with chaplains, with social workers, etc. Neuro-palliative care, if you're already kind of starting to guess, is basically palliative care for patients with neurologic diseases. It's a specialized form of palliative care tailored to these individuals with progressive, life-limiting neurologic diseases with unique needs requiring specialized knowledge and care. And as far as the Neuro-Palliative Care definition, okay, these are the two textbooks that exist, okay, only two. It's the youngest of the neurology subspecialties. This one was published in 2018, this one in 2019. The first Neuro-Palliative Care conference happened in 2021, so it's very, very new. But they came up with 5 principles, okay? And it's pretty much the same as palliative care. Emphasizing quality of life, enhancing the quality of life for patients with neurological diseases, managing symptoms and addressing physical, emotional, and psychosocial needs, providing support for patients and their families throughout the disease trajectory, assisting with complex decision-making related to the treatment options of end-of-life care, and assisting with neuroprognostication with the most up-to-date research. And neuroprognostication, if any one of us is very well aware, as we all are aware, is a very, very dicey thing to talk about, because we have all experienced people who come out of the weirdest, most catastrophic situations, and then some people that just crash after being seemingly normal. Okay, so let's go back to Gloria. Her hospital course progressed, and it didn't look good for her, okay? Her neurologic symptoms, her left-sided deficits were not improving after 4 days. But at least the troponin started to downtrend. During these 4 days, she had failed 3 swallow studies, and for 4 days had not been able to get an NG tube placed. She was not able to tolerate it despite sedation or despite anxiolytics or anything. She was just not able and unwilling to get it tried multiple times. She experienced constant anxiety and insomnia, which is very, very difficult to treat in elderly stroke patients. We were racking our brains around trying to figure out what would be the best strategy pharmacologically to try to treat these, and we couldn't find anything that seemed to work. She kept having intractable diarrhea, requiring extensive hydration. And because we knew it was a cardioembolic stroke, because we know she has surgeries and she has this giant thrombus, she had not yet gotten started on anticoagulation or antiplatelet despite that 1.5 centimeter mitral valve thrombus. So she was in a very, very precarious situation. And so at that point, she had at least 6 more of her children at bedside. And we asked her, because she was still sound of mind, what she wanted. And, in talking with my attending at the time, talking to other specialists, cardiology, like, oh, we can start the IV heparin. We can start doing this right now. It's totally fine. This is clearly a very survivable stroke, which we all agree. The stroke itself would not cause any death or major injury, maybe some left-sided morbidity. But people kept saying, this is survivable. She just needs to get the NG tube. We need to try again, et cetera, et cetera. But what did the patient want? Okay. She said, I don't want any more medications. Okay. I want to leave the hospital. I want to die in peace in my hometown, outside of Piedras Negras, Mexico, and I want to be surrounded by my family. Okay. So, but what would have been her prognosis? It's not that clear. Okay. And that's the thing. We don't know if the IV heparin would have helped dissolve the thrombus. She would have gone better. She would have gone through rehab. She would have regained her independence. All of these things are clearly a possibility. The alternative of her having further strokes, of having an arrhythmia, heart attack, something else, was also a possibility. And for those of you who didn't see it at the beginning, this was a stroke. Nothing, very exciting. It wasn't like a gigantic MCA stroke that is very debilitating. And so in talking about these things, and talking about prognosis, both one side and the other, what we could have done, let's talk a little bit about the 4 principles of medical ethics. Just a quick refresher. We know of non-malfeasance, do no harm. That's probably baseline. Everyone should know that. Don't harm anyone. Don't ignore people, the patient. Don't ignore their needs. But when it comes to palliative care, end-of-life care, things get a little bit confusing when it comes to beneficence. Because technically, it's all choices for a patient are made with the intent to do good. So the people who want to treat her thrombus, force the NG tube down, make her go to physical therapy, it is coming from a place of good. They want her to get better. They want her to regain her independence. Alternatively, let's say she wasn't able to communicate her choices, saying, hey, she's at very high risk, keeping her comfortable, making sure that she's not feeling hungry, that she's not feeling thirsty, that her diarrhea is under control, that her anxiety is under control. Let's just keep her comfortable, is also coming from a place of good. Okay, so both of them are fulfilling this ethical principle of beneficence. There's also justice, treating and providing care fairly to all patients. Doesn't matter if she speaks Spanish, if she's from Mexico, if she's undocumented, she gets the same level of treatment as anyone else. But here's where somewhat of the tiebreaker can happen, and that's autonomy. And I feel like sometimes we focus a lot on the kind of treatment that we want to offer, that just by asking the patient and their family what their values are can give us a lot better direction as to how we can best treat the patients. So respecting a person's freedom to choose what they want and what's right for them is also one of the 4. And at least when it comes to palliative care, probably the one that is most prevalent. Okay. So is there a need for neuropalliative care? Okay. In the olden days, okay, back when people got sick and miraculously got better or died, medicine really wasn't there to cure. It was actually quite rare for any disease that was chronic or debilitating to be cured. And basically all of medicine for most of human history was basically palliative care. It was all symptomatic management. It was all just covering the sick with a blanket so that they don't feel uncomfortable as they died. But things started to change. In the middle of the 19th century, this is Louis Pasteur. We started to figure out antibiotics. Diseases started to have cures. We started to feel like we had power over the things that we felt powerless against for the longest time. In the world of internal medicine, it was very popular, like all antibiotics, surgeries, heart surgeries, transplants, everything that you can imagine. Getting an appendix removed could now cure a patient of something that was a very painful death. So basically the whole idea of comforting the patient in their time of need and in end of life started to pull back a little bit. Neurology was one of the specialties that continued to experience, these kinds of conversations because most neurologic diseases are incurable. Multiple sclerosis did not have any treatments for the longest time. ALS still really doesn't have any treatment. Parkinson's disease, Alzheimer's, We now have more treatment. There's more disease-modifying therapies in MS than there like now in the last 5 years than there were in the previous 80 years. Deep brain stimulation for tremor and Parkinson's disease is now a treatment. We have TPA, TNK thrombectomies for stroke that can now save lives. Neurosurgery techniques that are becoming much more skilled and advanced are now saving even more lives. Okay, gene therapy for neuromuscular disorders, IVIG, plasma exchange. These are things we use all the time in the hospital that weren't really there, not even 10, 20 years ago. They were very rare. So even neurology, our diseases that used to be basically terminal and our profession that basically used to be a palliative care profession is now going into the world of medicine, where there are very successful treatments and maybe even cures soon. Okay. So, but again, most neurological diseases are incurable. Most neurological diseases shorten a person's lifespan. Most neurologic diseases reduce time to dependence and quality of life, basically morbidity. Most neurologic diseases are associated with pain, both or physical, psychosocial, psychological, spiritual. And with neurological diseases, yeah, morbidity is a bigger issue than mortality. I like to think of the difference between morbidity and mortality very quickly is morbidity is the number of years in your life. I'm sorry, mortality is the number of years in your life. Morbidity is the number of life in your years. Okay, so oftentimes a patient can be saved from a massive hemorrhagic stroke, but if they're going to live in an LTAC the rest of their life, that's a very, very catastrophic situation to be in. Sure, they're alive, but their morbidity is very, very severe. And in talking to some colleagues in palliative care and fellows in palliative care, many palliative care specialists experience neurophobia, like many other people who are trained in internal medicine and other specialties that are not neurology. And for our palliative care colleagues here, I made a little pie chart of the people who have joined our palliative care program, at least for the last 5 years or so. And as you can see, most palliative care providers are internal medicine trained, about a third are family medicine trained, and then about 20% are a combination, anesthesia, pediatrics, emergency medicine. One of them was radiation oncology. So as far as our program, I don't know of anyone who's been neurology trained joining our neuropalliative or our palliative care program. And so again, just to rehash, with a growing number of treatment options, neurologists and neurosurgeons increasingly feel less comfortable engaging in goals of care discussions, okay? And this is something called thanatophobia, the fear of death or conversations about death. And so addressing these issues tend to be like pushed down the road until it becomes inevitable. And I encourage you all to at least pull back and think, well, if someone is coming in with something that's life-threatening, have those conversations early, because you never know what the patient's values might be before they get intubated, before things get worse. Okay, so some unique features on palliative care, on neuropalliative care. I mentioned the illness trajectories and prognoses are all over the place, okay? We have multiple sclerosis where we have a predictable decline with some flares that make someone, a little bit weaker temporarily, and they go back to a new baseline and then a new baseline until death occurs. We have a ALS and cancer where people are seemingly normal, and then there's a giant drop in terms of their morbidity, and then they often pass away very quickly. We have things like Parkinson's and Alzheimer's disease and such that people have a very low level of function for a very long time before they die. And then we have things like severe acute brain injury, whether that's traumatic or stroke, and really we have no idea, unfortunately, which I feel like there's a lot of research that can still be done to get better accuracy at prognostication. So I'm going to run through these very quickly at the end, okay? So illness trajectories and prognostication. Level of symptom burden with or without treatment, risk of decompensation, risk of complications, comorbidities. These are features of neuropalliative care that need special attention in people, especially in the neuro ICU. Symptomatic profiles, okay? Patients who have neurologic diseases experience seizures, cognitive decline, behavioral deficits, headaches, paresthesias, weakness. Oftentimes, in palliative care, managing seizures is not a strong suit of the palliative care department because they're not as knowledgeable about seizure management. or tremors or weakness even, depending on the kind, if it's neuropathic versus not. So there's a lot that neuropalliative care can contribute in patients with neurologic diseases with specialized training. There's, of course, existential and psychosocial suffering. There's loss of personhood, which is very catastrophic. We just recently had a patient that had basically bilateral ACA stroke, basically got lobotomized, but she's going to survive. But having a conversation with the family about her deficits is something that we needed to do from the beginning. There's demoralization, the fact that you're not going to be back to the person you were before. There's a loss of independence. Some people pride themselves of being independent. There's memory loss, forgetting your own children, your parents, your friends, behavioral changes, and caregiver burnout specifically. When a patient leaves our ICU or they leave our wards and they go to an LTAC and then go home with significant morbidity, there's caregivers on the other end that have to deal with all of these conditions. Okay, so what do caregivers have to deal with? They have to deal with treatment decisions, depression, loss of productivity because they have to quit their job to take care of their family, loss of independence themselves. Even though they're perfectly independent, they have to take care of a spouse or a parent or a child. Lack of resources. Okay, they have to spend a lot of extra money on taking care of their relatives. And then there's this notion of miswanting. Miswanting is a very interesting definition. It's in the context of end-of-life care, it's decisions, family members, miswanting in the context of end-of-life care decisions for a family member who can't make decisions for themselves might involve mistakenly desiring something that won't actually lead to the best outcome for the person. For example, if a family member might miswant by insisting on aggressive medical treatments or interventions because they fear letting go or feel guilty about not doing everything possible to prolong their loved one's life. However, these interventions might only prolong suffering without significantly improving the person's quality of life. In this case, miswanting arises from an emotional response rather than a rational assessment of what is truly in the best interest of the person. And sometimes, because it's a family member making the decision, we just say, okay, family member made the decision, and we just leave it at that. But some of these family members need to understand, need special counseling, need to talk with a chaplain, need constant conversations about the illness in order for them to come to an understanding and not feel the pressure or the burden of miswanting for their loved one. Thankfully, though, I consider Miss Gloria's ending a bittersweet one. Okay, she said things that often we hear in our patients. I don't want to be a burden. I don't want to be dependent on others for basic needs. I don't want my personality to change. I don't want to suffer. When I die, I want it to be without pain, in my own bed, surrounded by my family and loved ones. And isn't that a better ending than in a hospital bed where only one or two of your children can be there in pain and suffering? It depends on the patient's values. It depends on what they want for their autonomy, what their choices are. If they wanted one frame of treatment and it's consistent with their values, let's do that. But if it's inconsistent, that leads to even more suffering. So let's do a little bit more to at least focus on the patient's autonomy and listen to what they have to say. So with that, I just want to end with the gentleman you saw in the caregiver burnout picture. This is my grandfather, okay, Oscar. He died of Alzheimer's disease. He had Alzheimer's for about 5 years, from the age of 87 to 92. And it was very difficult to see my grandmother also dwindle while taking care of him. My mom lost productivity going in and taking care. But he made his wishes known even before he was diagnosed with Alzheimer's. Said, don't ever send me to a hospital. I want to be at home. And he died surrounded by his family, in peace, in his own bed. That's what I want for all of us and for our patients, to have dignity in death and to have a beautiful death where you remember them positively and not under code status. So thank you very much. Yes.
Thank you. That was very, and to me, the elephant in the room is what's happening now with suicide, assisted suicide in these patients who want to dignified. You know how the medical community neuropalliative care is approaching these questions?
I wish I knew more. I know there's a handful of states that legalize it, and there's certain requirements, like you have to pass, you can't be depressed, for example. You have to be of sound mind, and oftentimes it's mainly with terminal cancer, glioblastoma primarily, because that's the one that has the most rapid progression of disease burden. As far as other neurologic diseases, ALS, I think, is one that people are considering for assisted suicide, but I'm not really sure about things like dementia, because dementia, at that point, the patient cannot really make their own decisions appropriately, unless, of course, they have this advanced directive maybe years before where they say it. So there's yeah, it's an interesting question, and I wish I knew more. Just saying with that. Anyone else? All right. Thank you so much. I'll pass it on to Maggie.
Eithan, how do I make it show my notes? How do I make it show my notes? Sorry. Should I just do this and then present?
Oh, yeah.